we keeping cameras on at this point?
I think it's up to you, Adam. You can keep the camera on if you want to. I think as long as we're all just muted when we're not presenting or speaking.
Have we warned Tim that if he's going over time, we're going to signal him to stop?
How much time have I got?
Hello, Tim. You've got, ages, 13:35 till 13:50.
Okay.
So if you seem to be in full flow and we've got a couple of minutes to go, I'll put my face on and give you a little nudge. All right?
Yeah, absolutely. I mean, feel free to say, "Shut up."
I'll try and do a little bit more politely than that. But thank you. Nice to see you.
Yeah, nice to see you all.
You too. Hi, Tim. Well, we're at 1:30. Shall I make a start, even though people are still coming in, do you think?
Yeah, I think that would be best, Bryn, just so you can try and keep the time.
Okay. Well then, hi everybody. Thanks very much for coming. This is a event hosted by the NIHR Mental Health Policy Research Unit, and we're thinking about the immediate impacts of the COVID pandemic and future focuses for research relating to sort of mental health care and the impacts for the people using mental health services. So I hope that's what you're here for. If not, now would be the time to make your exit. My slide is not moving on. Sorry. I just can't make my slides move at the moment.
Okay.
Try once more. Still not moving now. So I'm a bit stuck with the slides. I'll talk anyway while we try and sort that out. So we have two aims to do today, really. One is to kind of share research that's already happened on the kind of impacts on mental health care of COVID. So that's research done within the Policy Research Unit team and by our invited speakers. And then we want your help to kind of discuss and try and set some priorities for what needs to happen next in terms of research and understanding and addressing these impacts for people using mental health services and for mental health care. So there are a few kind of housekeeping things just to say first. First of all, to let you all know, remind you that we are recording this event and we're live streaming it. And we will also save the chat at the end. So this will all be public. Because we're a large group, we've got a lot of people coming. Please, can you stay on mute when you're not speaking? And if you want to kind of make comments or ask questions, please could you use the chat to do that? We'll have a brief bit in the first half and a longer session later where there'll be a sort of Q&A, where there'll be a chance to air comments, but we can't sort of interrupt as we go along because we're keeping to quite a tight timetable, please. You can also contribute to this event via Twitter. The handle is #COVIDMentalHealth. And if you're having any technical problems like I'm doing now with my screen, could you try contacting Andre in the chat, please, the mental elf. Contact him privately and he'll be able to help. So the basic sort of plan for the day is in two halves. So the first half of this talk is some presentations and then discussion of research that's going on. And then after the break, we'll have some small groups where it's your chance to sort of tell us what's important really and what the priorities are for sort of future research. We'll then have a discussion with an expert panel who you can ask questions and get the sort of thoughts from and responses from. And we'll end the day with a kind of exercise where we try and set some priorities. So from some of the suggestions for future research questions, which you provided when you registered and which we generate from the breakout rooms today, we'll ask you all to tell us which are the most important of those which for taking forward. So that's the kind of plan for today. I've got a disclaimer slide, which is basically to say that the Mental Health Policy Research Unit is funded and commissioned by the National Institute for Health Research through the Policy Research Programme, but that anything that we say today represents our views, and anything foolish we say is certainly our fault and not the fault of the Department of Health and Social Care or an AHR or its arm's length bodies. So we don't speak for them. We all don't speak for them except for our first speaker, who certainly does speak for NHS England, because he's the mental health director for NHS England, and that's Professor Tim Candle, who we're really pleased to have here today, who's going to do an initial talk to sort of set the policy context and scene for us. So I'm struggling to move my slides on, so I wonder if I can stop sharing. Does anybody else have Tim's slides, like Christian or Zainab, which you would be able to share? See if that works any better.
Yes, I've got Tim's slides, so I'll try sharing them now. Hopefully that works fine. Okay. Is that moving along okay?
Yeah, that's fantastic. Thank you very much. Well, thank you for asking me to come and talk, Bryn. I'm going to give a very brief background about what we're doing and what the impact of COVID has been, both in terms of the impact on people's mental health, but also the impact on services. So next slide, please. Okay, so for the long-term plan, for those who don't know, you know, we got 2.3 billion extra money per year by 23-24, and that's on top of having an extra £1 billion a year for the 5-year forward view, which ran from 2016 through to next year, to April next year. Now, all sounds fantastic. You sort of think 2.3 billion, 3.3 billion. Try and remember that in 2016, when I first started this job, we had a treatment gap of in children of about 3/4 of children who had a mental health problem that you could identify in the community, a diagnosable problem. 3/4 of them were not getting any treatment. And for adults, that was just under 1 in 3. Now, I don't recall any other part of health that had that kind of treatment gap. So very important to bear that in mind when I talk about these wonderful sums of money and the additional people that we're going to see. So, you know, our long-term plan was to increase the number of people we see each year by 2 million people. And you can see in those squares in front of you the different areas that we're going to do that. So perinatal, children's mental health, developing a new service into schools. And the biggest chunk of it is going into community mental health for adults, where £1 billion a year by 23-24 will be available. So, and when I think of what that really amounts to, you know, you're talking about in Sheffield, which has got a population of 550,000, that's an extra £10 million per year on top of what we've got just going into the community. Next slide, please. So these are the things that we've achieved. We now have perinatal community teams across the country. In 2016, that was at 15%. We have moved from 1/4 of children being seen up to 36%. So we are on the way to improving that, and we're going to keep going with that. We have now got, this slide's slightly out of date, we've now got 180 mental health support teams working into schools, and we think we will exceed our target of 25% of the country being covered by 23-24. I think we will exceed that. We've also, we are now hitting nearly 90% of all children with an eating disorder under the age of 18 are being seen within 1 week if it's urgent, and within 4 weeks if it's routine. And that's getting treatment started within that time period. A&E departments, we've got every A&E department in the country now has a liaison team, and by next year, half of them, we're quite close to it, half of them will have a consultant within that team. We've set up 12 implementer sites for the community developments, and we are reviewing those. And on the basis of that review, by April of next year, we will start the national transformation program that will take 3 years to invest an extra £1 billion in community mental health. We've set up stuff in gambling, and we've also got stuff for rough sleepers. Next slide, please. Okay, so COVID. I mean, you know, it's a bit daft me telling you what the impact of COVID is. I think everybody on this call will know that. But let's sort of have a look. There's obviously been, you know, lots of people have died. That's absolutely true. We know that, you know, week by week, that a lot of people, anxiety levels, levels of depression have gone up. And nowhere is that more, has that had more impact than amongst people with existing mental health problems. You know, and that includes both common and more serious mental health problems. We're seeing people coming out of ICU who survived COVID to find that they've got two problems. That one is what's being rather strangely called long COVID, but probably much more importantly in a way is actually about 1/3 of people coming out are having PTSD. We also know that staff have a great deal of problem, and staff working on ICU, quite large numbers are developing PTSD. There's also good evidence about rises in domestic violence during the lockdown and problems amongst kids. So kids appear to have increased difficulty of various kinds. And then, you know, on top of that, we've got to look forward to the impact of a recession that we're going to have with debt. And I can tell you, working as a homeless consultant in Sheffield, homelessness has already started to go up, as has the mental health problems that go with that and the substance misuse problems. And throughout this whole period, the consumption that the population have had of alcohol has gone up very substantially. Next slide, please. Impacts on services. If you see on that slide, the blue bit is the referrals into IAPT. They fell off a cliff. Those entering treatment is the orange line, and the grey line are those who finish treatment. Now, as you will see, I mean, this happened across all services. Referrals went down, and you know, our engagement has gone down. Now, with a lot of services, that's not quite reached full as it was pre-COVID. But we're getting there. Interestingly, what IAPT did was to go online. So 95, I think that may be in the next slide, but 95% have shifted onto shifted IAPT services to either phone, or they've gone on to video conferencing, video conferencing for therapy. And importantly, that is rising and continues to rise. So we're up at sort of 10% now are using video links, and that's growing. And you'll be pleased to know that the recovery rates in IAPT have actually improved during this time, and the sustained improvement has also improved. Now, shortly after lockdown started, the referrals into acute mental health absolutely plummeted, and although that did come back up, it took quite a while to do it. And I'm sorry to say that we had a massive improvement in out-of-area placements in the first period because you didn't need to send them out. But we are now exceeding our out-of-area placements in acute care. Next slide, please. So what else have we done to step up to this? As I say, a lot of services are now using telephone. I mean, in my own service, which is for homeless people, I'm using phones to contact people who are in supported accommodation, which has been sealed off during lockdown, so where you can't go in. But for most people, I'm continuing seeing people face to face, but with social distancing. One thing we did do was we advanced all of our programs around crisis lines. We were planning by 2022 to have every part of the country having a crisis line that you could phone 24/7. We now have achieved that already. So that was in place by May or June of this year. So that's all gone well. The children and young people, we have got our mental health support teams back up, and now kids are back at school. They're growing again. We've also published stuff on health inequalities, how to overcome that, particularly around Black and minority ethnic groups. Final thing is staff, I think, on the front line have had a pretty tough time during COVID. And we managed to get significant investment, I mean, millions of pounds, to make sure that we now have hubs in every STP that will be there specifically as a sort of mental health service for NHS staff. And they will be able to plug into the program that already exists for doctors and dentists, the practitioner health program. So that will be opened up over the next few months. Now, it will take time to get that up and running, but we have got inward investment for that to happen. Next slide, please. Impact on delivery of national priorities. I mean, I've sort of said this already. To begin with, it's been quite hard to actually keep some of the national priorities going, not least of which was getting our mental health program into schools up and running, because that involved, rather like with IAPT, it involved us putting people into schools and then training them on the job. Well, you can't really train them on the job if all the schools are shut. But as I say, that has now got back to where we were. We've had a similar sort of problem with early intervention in psychosis and IAP. But I'm pleased to say that that's pretty much sorted out now. Next slide, please. So what are we going to do next? As everyone again on this will know, we've got 107 people dialing into this. We are now able to do stuff with online that we could have done it before, but we didn't. And Microsoft Teams and different platforms that we're using are now being used for clinical work, for team meetings, clinical team meetings, for training programs. So someone's got their microphone on and making a terrible racket. Yeah, still making a racket. The emergence of Microsoft Teams and Zoom and so on has made a major difference. Now, IAPT have done a teaching program for existing therapists so that they can train people up to do work with PTSD, but specifically for people coming out of ICU. And to do that, they've managed to do a training program with 1,800 people, all dialing in at one go. So, you know, we're able to do things that we couldn't do before.
Tim, we need you to wind up in a minute or so. Thank you.
Okay, we wound up very quickly. So it's lots of opportunities with digital and remote working. And students, for example, can access IAPT and so on without having to, you know, they can do that back at home. So we are going to do two things. One is we're going to drive through the long-term plan, which we think is the most important response to the mental health problems arising from COVID, alongside accelerating all the crisis stuff that we've done and consolidating our gains with distant working. So on that note, I will now finish, Alan.
Thank you, Jim. Thank you very much. It's great to hear from you. Thanks for that, setting the scene for us this afternoon. My name's Alan Simpson. I'm Professor of Mental Health near St King's and co-director of the Mental Health Policy Research Unit. It's great so many of you have joined us this afternoon. We're not going to hang about. We're going to put up the next lot of slides. And you'll be hearing from three of our fantastic researchers in the Mental Health Policy Research Unit, Christian Dalton-Locke, Luke Sheridan-Rains, and Nora Vera Sanflan. And they're going to be talking to you about international synthesis of literature around the impact of COVID in mental health and on our survey of staff. So I'll hand it over to Christian, Luke and Nora. Thank you.
Thank you, Alan, and thank you, Tim. So just before we start, I think Bryn went over some of this information already, but just to say that this presentation presents independent research commissioned and funded by the NIHR Research Policy Research Programme, and the views expressed are those of the authors and not necessarily those of the NHS, the National Institute for Health Research, the Department of Health and Social Care, or its arm's length bodies and other government departments. So, as I'm sure you're already all aware, the World Health Organization declared COVID-19 as a worldwide pandemic on the 11th of March this year. There were concerns and uncertainties about how the pandemic may affect mental health care and people with pre-existing mental health problems. However, most of the focus was of the impact on the general population and their well-being, rather than much research going on. There wasn't much research going on about people who already had mental health problems and how the mental health care systems might be affected. So we carried out two studies with the same aim of investigating the early impact of COVID-19 on mental health care. The first study was an international synthesis of reports on reporting on the pandemic and how it may affect or impact on mental health care. And the second study was a survey of UK mental health care staff. So the international synthesis of reports, it was a very broad search, which included searching Google and online databases of scientific articles for any kind of report which did report on the COVID-19 pandemic and how it may affect mental health care and people with mental health problems. So this included first-person accounts, media articles, and publications by governments or charities or professional associations. All the articles to be included in this synthesis had to be published before the end of April. We searched for articles in English, French, German, Italian, Spanish, and Mandarin Chinese, and included 872 articles from 28 countries. Most of these articles were from Europe, but there were quite a few also from South America, Australia, New Zealand, and China. Most of these articles were online media articles based on observations or experiences rather than scientific articles based on art data, because there just wasn't much of it available at the time. And then these articles were synthesized by a group of researchers, including researchers with lived experience and clinicians, to draw out the key themes from these articles. And then on to the methods of the UK survey. So there wasn't already a measure that looked at the impact of the pandemic on mental health care. So we developed an online questionnaire to collect cross-sectional data. Initially, this was done by the lead developer, who's an academic and clinician, based on key themes that were being drawn out from the international synthesis. But then initial drafts of the survey were sent out to groups of researchers, clinicians, and people with lived experience for their feedback and any further topics to include. And the final survey included open-ended questions and structured questions and 3 main sections, which were current work challenges, problems currently faced by mental health service users and family carers, and sources of help at work during the pandemic. Our approach to recruitment was to try and get as many staff as possible from a wide range of settings and sectors. So we approached various channels or shared the survey of various channels, including professional networks, social media, mainly Twitter, with the help of the mental health, and relevant mental health focus bodies, including the Centre for Mental Health and the Association of Mental Health Providers. The survey was launched on the 22nd of April and closed on the 12th of May, and 2,180 staff completed the survey. Almost 90% were working at NHS. Most were working in community settings, so there was quite a substantial number working in inpatient settings. Most were working in England. 4 out of 5 participants were female. And unfortunately, there were very few participants from Asian or Black minority ethnicity groups. I'm going to pass over to my colleague now, my colleague Luke now, who's going to be presenting the results from both the studies.
Thanks, Christian. So my name is Luke Schoenrains. I'm one of the research fellows in the PRU, and I'm going to be presenting the results, as Christian said, of the 2 studies. I've merged them together because there was quite a lot of overlap, particularly on clinician experiences and perspectives. And I should just highlight the fact that these results come really from sort of before the end of April this year. So they were kind of early impacts or early reactions to the pandemic. And what we found was that I think overall the story with inpatient facilities was that in many cases wards were being repurposed. So in some cases, wards would be repurposed for people who had COVID symptoms. In other cases, wards were being used for people without COVID symptoms, and some were being used for people in quarantine, so who had been recently admitted. There was also the introduction of social distancing rules, of course, and the overall effect was that inpatient capacity reduced quite significantly. So admission rates fell, and that was partly due to the threshold for being admitted to hospital. Clinicians reported that as kind of increasing, but in some places, so the survey, sorry, not the survey, the review in particular was kind of international, had an international focus. So in some places, clinicians spoke about quite rapidly discharging people into the community where they wouldn't normally. Some of the challenges that came with that included the fact that there were concerns about discharging people into communities when community services may be shut or significantly reduced in terms of their capacities. But there are also, clinicians also spoke about ethical concerns. So one of the things that they were concerned about was social distancing measures, basically meaning that people couldn't go on leave, or couldn't see family and friends, or found it much more difficult to speak to family and friends by phone. And also then staff were concerned about not being able to adequately provide care for their patients. Sorry, yeah. In community settings, as I mentioned, many services, so this was quite variable around the country. Some services shut altogether, while others had much lower staffing levels than normal. Clinicians spoke about their concerns about infection rates between their clients, but also amongst their colleagues. And there was also a very rapid and widespread implementation of telehealth measures. So this included, video calling and supporting people by phone. However, this wasn't done everywhere, and some services had kind of poor technological resources, or clinicians felt that they hadn't been given adequate training in advance. And equally with some service users, they also lacked sort of technological access. So maybe their internet connections weren't good enough, or they lacked the expertise to use the new technology. But some also spoke about the fact that they didn't really have anywhere good to make these phone calls. So they lacked privacy at home to have a good kind of conversation really with their clinician. Some also spoke about the potentially negative impacts on rapport and therapeutic relationships with their clients. And as the kind of another key aspect really of community care was that clinicians felt less able to signpost or refer to other services. So while their services were being reduced in terms of in what they could do, other services were also shutting down. So there were kind of reports from some service users of just having very occasional phone calls with their clinicians, and maybe at most clinicians could sort of signpost things like suicide helplines or the very occasional third sector organization that was still open. Yeah, Christian, do you want to change the slide? Okay. So in terms of service user experiences, at that time, I think the key thing that came out was the perception of deterioration in their mental health. And this was particularly associated with conditions like depression, anxiety, OCD, and eating disorders. Some of the reasons for this deterioration included health anxieties, concerns about contracting COVID, and also the consequences of doing so. But other drivers included the loneliness and isolation that came from the lockdown, the withdrawal and reduction in services, and the potential societal and economic impacts of the pandemic. So in some cases, like depression and anxiety, it was driven quite straightforwardly by these things. In the case of something like eating disorders, it might be that a person's normal routines or coping strategies had been significantly disrupted, and their ability to kind of cope or maintain their own mental health was diminished as a consequence of the lockdown. Okay, Christian, do you want to? So, but there was also a kind of silver lining really to the pandemic for some people, to the lockdown for some people, which was that there was a sense amongst some people of a sort of shared trauma. For some people who perhaps were already quite isolated or already found it difficult to attend services face to face, some of them reported that the experience of being locked down was actually sort of similar to their lives anyway, and it actually helped them feel better understood by others, and that there was a sort of greater, they felt sort of greater empathy almost from other people. Some people spoke about the significant benefits of remote working. Again, people who may be kind of feeling already quite isolated or unable to attend clinical teams for whatever reason, they actually quite liked the introduction of remote working or telehealth measures. And it was something that they hoped would continue on at the end of the pandemic period. Equally, we also saw a significant growth, people were reporting anyway, a significant growth of online peer support. So again, people who perhaps would find it difficult to access peer support in the community normally were better able in some cases to gain peer support in the lockdown period. So those are the sort of key messages really from the results. I think that the what we found was very rich, and we have these two quite dense papers that are out. So I've just tried to focus on the sort of key messages really. So at that point, I'm going to hand over to my colleague, Nora, who's going to go through the discussion.
Thank you. So to summarize the results that Luke just presented, the key points, we have clinicians reporting immediate service challenges, mainly related to controlling infection in inpatient and residential settings, and the implementation of telehealth in community health settings. Specifically, the challenge was combining infection control measures while still maintaining an adequate therapeutic environment. We found many reports of implementations and of adaptations and innovations, which were considered to be very useful and that they were working well. But at the same time, there was also ethical challenges and significant concerns for the future. Among service users, we found many reports of symptoms deteriorating and increased loneliness, social isolation, and lack of access to services and resources. And on the other hand, we found reports of resilience and effective self-management and increased peer support. Next slide, please. Our study had strengths, but also had limitations. So our work included contributions from experts by experience and clinicians who were involved at all stages of the research, planning and conducting the research. But the day-to-day management of the research was mainly driven by academic researchers. We collected a very large amount of material and had to analyze it using rapid methods and then compress it to fit the journal's word limit. So we encourage people to take a look at the supplementary material, which provided more detailed information, and to get in touch with us if you would like any more details as well. And there's a level of response bias in our sample in that people who participated in the survey or who wrote reports which could be identified online are more likely to have strong views. And at the same time, the voices of populations who are digitally excluded would not be included in our findings. Next slide, please. So, as mentioned earlier, our team includes researchers with lived experience of mental health problems, many of which have joined us today. And these experts by experience wrote commentaries about both of the studies. And I will outline here the key points that they raised regarding the systematic review first. So despite including a wide variety of information sources, there was still an absence of minority group perspectives and an absence of reports informing of the impact of COVID-19 on Black and Asian minority ethnic groups in particular. This was at the time. Now we have a bit more information about this, but it was a limitation at the time. There was an increasing deprivation of rights of patients that came from the fear that people with mental health problems cannot keep social distance adequately. So examples of this were reducing the number of clinicians required to admit people under the Mental Health Act, or also inequalities in the care of COVID patients with mental health problems when compared to COVID patients without a diagnosis. In relation to inpatient ward design, there was a comment that it will require further attention to allow for segregation without engaging in unethical use of sedation or restraint. Lastly, people's ability to self-manage in an emergency context should not be framed as resilience if it was the only option available. So people being able to respond to an emergency shouldn't be framed as resilience and therefore services being taken away or shut down. Next slide, please. With regard to the survey, the lived experience researchers commented on the concerns shared by both staff and service user. These included premature discharges, unethical isolation, difficulties with infection control, and difficulties for patients accessing care. They highlighted that these concerns were reflected in the Mad COVID project. This is an online space to share projects developed by mental health survivors and service users during the pandemic. The unethical restraint was brought up as a vital issue that required attention. So staff mentioned that they had struggled to put on appropriate protective equipment to deal with ward emergencies, and that there's a risk for patients being blamed for viral spread without looking further into the multiple factors that really lead to emergencies arising. So this could be contextual stressors, things that make fear arise in patients or anger. And these are situations that could be avoided and should be further looked into. And experts by experience have campaigned for changes in mental health services for decades without a lot of success in some occasions. So the speed at which the latest changes have taken place really shows that it is possible, and it shows that non-COVID related demands can be addressed with the same urgency. Next slide. Specific concerns about having therapy from home were also pointed out. So not everyone has a private space at home where they can have private conversations in. It is potentially important for distressing conversations to take place outside of the home. Video calls may feel invasive, like the clinician is in your room or in your personal space. And there is a need for considering safety implications of remote healthcare that I think Sonia will talk about further later. And in terms of implication for the future, so this is implications of our research findings, we can take this as an opportunity to establish new ways of working and rethinking the conventional approaches that we had been using up to now. For example, by collaborating more with service users and carers and the third sector organizations to develop support networks further. So collaborating with housing, education, and employment services, for example. We can continue the implementation of effective technologies, so things that have worked and could be kept for the future. And service users and service providers are coping with multiple challenges and changes at the moment. So it's on both sides, and training needs to be developed to help them navigate these new tools for service provision, and considerations around patient safety particularly will need to be reassessed when using these new tools. Challenges to implement rapid research methods. So in this emergency context, we do have to implement new research methods, and it will be a challenge to continue having multidisciplinary groups and allowing enough time to discuss research plans from different perspectives and allowing time to carry out the research in a manner that doesn't affect the well-being of all of those participating. Thank you.
Thank you very much, Nora. Thank you, Christian. Thank you, Luke. The papers that the speaker's referring to, the links to those are in the chat on Zoom, so look out for those. Thank you very much. In amongst the Mental Health Policy Research Unit team is a large body of people with lived experience who are working with us as researchers on all of these projects. And up next, we have one of those, Kerry Dare, who's going to be talking about some of the results of our interviews with mental health service users, supported by one of our research team, Una Foy. So I will hand over to Kerry and Una. Thank you very much.
Hello, folks. So I've been asked to talk about our paper, the experiences of living with mental health problems during COVID-19. But actually what I'm going to talk about mostly is the experience of conducting research during a pandemic, particularly as part of a team with a large number of lived experience with researchers, of which I am one. COVID, as you all know, is a bit shit. It means we've had to deal with a lot of new ways of working in mental health services, increased in demand for services, and new ways of doing things. So pretty much as soon as the pandemic started, then we were asked to carry out a piece of research looking at what it's like to be on the receiving end of these changes. And I'll admit I was a bit cynical about this at first. Funded by the Department of Health and Social Care, they particularly asked us to look for positives on new ways of working, which like positives from COVID, and I have strong reservations about digital and who it excludes. And I was a little bit worried that this was going to be essentially an excuse from the DHSC to go take everything to digital and sod anyone who can't use that. So started, I think in March, very early on, sort of quick and dirty, throw together things as fast as we can, essentially repurposing an existing study on the mental health impact of loneliness, and adding some questions about COVID and its impact. Participants were recruited through social media, which, you know, has a pretty obvious bias in terms of who you're going to get to participate. You're only going to get people who are already very comfortable with digital and with seeking support through digital and so forth. This is largely because it was pretty much, it wouldn't have been possible to go through NHS ethics in the time. And I actually wonder if that's something putting into pretty strong feedback to the NHS ethics committees about, because we need to learn how to do research that needs a fast turnaround time. It's part of learning how to deal with pandemics. We have a vaccine now because of lessons which were learnt from developing during the Ebola pandemic. Why should mental health be any different? So we had 49 participants recruited through social media, pretty much because that's what we could manage. We were analysing the data as we went along, and where there was some impact whereas we were looking for data saturation, then there were also a lot of practical barriers around what we could actually do. We would particularly sought out BMA participants, a range of diagnoses. We managed to get a few people with psychotic illnesses, which was quite difficult to find. And to a small extent, we were looking at age, gender, sexuality, and rurality. But in practice, it was pretty much whoever turned up. So lots of practical obstacles to trying to throw something together this fast. Working across organisations, things like logins, software access, email torrent, everyone tried to get used to working across a whole different loads of platforms at once. I still haven't got the hang of Slack. And that's quite overwhelming in a lived experience researcher who, you know, I signed up for the lived experience working group on the basis that it would be maybe a day or so a month, and all of a sudden I'm pretty much working all the hours I can manage. It was quite an overwhelming experience working on the study, to be honest. I don't usually research things at the same time as I'm experiencing them myself. So, you know, I looked at the experiences as people who've been sectioned, or the experiences as people who've wound up in the police cell after section 136, which would be pretty difficult for me. But I'm not going through the exact same thing at the exact same time myself. And the problem is that as lived experience researchers, not only are we in general stuck on 0 hours contract with no sick leave, I didn't even get sick pay for the point I was sectioned, then we also don't have access to a lot of resources that researchers who's actually got full-time regular contracts have, things like university counselling services, which is increasingly being seen as best practice for all researchers, welfare provision, not just for lived experience, but lived experiences seem to get least access to them. The ethics of doing research on participants with pre-existing mental illness in the pandemic was a complicated discussion, and there were some voices saying, well, maybe we shouldn't be doing this at all, because obviously you're talking to people who already have mental health problems, who are facing a new and distressing situation at a time when their usual supports might be absent or more difficult to get hold of, or they might have had it removed or be having to work in different ways, certainly. So yeah, that's a lot of setting things up. The demographics of the people we recruited pretty much reflects the recruitment online. 86% of them were using some sort of mental health services. Half of them were Londoners. 13% of them identified themselves as Black, which is in line with figures for London, but compares to 3% of the UK population. 12% as Asian. Again, that's a bit of an overrepresentation for the UK population because we were deliberately trying to recruit BAME groups. 69% of our participants were female. Again, maybe that's who's confident to talk about the mental health online. And only 14% of them were over 55. So results, what did we actually find after all that? The core themes were around impact of changes to mental health care, that people lost their usual support and felt that some people could engage well with online support, some people couldn't. It was harder work, especially to agree to get into, and the feeling that professionals were firefighting rather than providing planned care or missing out on care. I'd say for myself as well, it's actually been really interesting getting a view from different geographical areas of the country and seeing that, you know, some areas have put in a lot of support for people, some areas have put in nothing at all. And these impacts were quite unequal in pretty much many cases, the ways you might have predicted unequal impacts before the pandemic, in terms of participants with disabilities affecting their computer use, with limited finances, limited access to technology, people living in overcrowded housing with no privacy, that sort of thing. And again, there was difficult, unequal impacts of lockdown around stigma and judgment, because people often were talking about feeling quite stuck with their mental health problems around being around their families and communities, and without usual support from services. In some cases, this was particularly difficult for people from BMAE communities because they felt more at risk for COVID, and in some cases, specific religious or cultural needs were difficult. For example, one participant reported needing to get up at particular times to take her medication while the rest of the family was marking Ramadan, and that being quite tricky. Psychological impact varied a lot, no hugely clear pattern on that. And another thing was relationships, connections and disconnections. And some people felt that, you know, being forced into lockdown, being forced into very close proximity to people, found that increased connection very difficult, whereas others were, of course, missing the connections that they had every day, even quite small things, just going out and being able to see other people. And there was a lot about losing informal peer support from friendships formed within services. This was particularly an issue that even when you got to your services via Zoom or in a COVID-safe manner, then people still weren't meeting each other for smoking breaks or in the waiting room or anything like that. there were a lot of everyday practical issues. Everyone experienced some difficulties with those during lockdown, but for some people with mental illness, then that was more difficult to cope with. Fewer resources, fewer connections to manage this. Some people talked about, for instance, being discharged from hospital into lockdown and how they were suddenly at home with no way to buy toilet roll and so forth. So yes, our findings complement research exploring existing experiences of staff and other service users. Data look at, there's obviously some pretty different effects of COVID-19 for people with different mental health conditions from different backgrounds and so forth, in ways that might be interesting to explore in the future. Further research would be good on the longer term impacts of COVID-19 on people with pre-existing mental health conditions and on mental health services, and how changes that has been put in place during the pandemic do continue or don't continue. And we particularly need to look at inequalities of impact around mental health and all the usual intersectional things, Black and minority ethnic communities, low income groups, poor housing, that sort of thing.
Thank you, Kerry. Thank you very much. Is that you finished? Thank you. Una, were you going to add anything?
I think what I would add is just being able to build those skills as a researcher alongside the lived experience research team has been absolutely incredible. And I think it shows that we can do research well with lived experience researchers in ways that I think institutions and organizations haven't thought about before or haven't necessarily pushed to the forefront. And I think this team has shown us that. And really, to me, the core message from this paper was that we're all in this together is a lovely phrase, but actually some people are much more impacted by the effects of COVID than others. And I think those with mental health problems before COVID are one of those groups. So we're not necessarily all in it together. We have different starting points.
Thank you very much. Thank you, Una. Thank you very much, Kerry, for that. The link to the paper that Kerry's been talking about is in the chat. There's a second wave of interviews conducted about 3 months later with the same people about their experiences to look at what's changed, what's remained the same, what's developing. Hopefully that will be published at the beginning of the new year. It's worth saying that it was, as Una said, it's a great experience working with our lived experience researcher colleagues, and a big challenge for all of us. We were all learning how to work remotely, working as part of large teams, having regular meetings, using Slack, using Zoom, Teams, and all the rest of it. And all these interviews were conducted remotely. So it's a big learning curve for everybody. And we certainly have valued and appreciated the enormous input from our lived experience research team and those who supported them, which include other people with lived experience. And it's worth saying as well that anyone who took part in that, they were invited to take part and could do as much as little work as they wished, and everyone was offered ongoing support, including reflective group spaces, which I think were generally very well valued. But important work, big challenges for everyone involved. I know we've learned lessons for thinking about how we might do things a bit different next time. But thank you very much for that. I'm going to move on because we are slightly over time. So I'm very pleased to say that as well as people from the Mental Health Policy Research Unit, we have a couple of speakers from some of our colleagues elsewhere. And first up is Rob Stewart. Rob is at King's College London Institute of Psychiatry, Psychology and Neuroscience, and he's got interest in the epidemiology of late life mental disorders and the interface between physical and mental health. But he's particularly going to talk about the work that he does using the Clinical Record Interactive Search Data Resource, or CRIS, which is at SLAM, South London and Maudsley. And they've been doing some really interesting work and publishing some excellent work around the impact of COVID-19 on mental health services and their service users. So, Rob, thank you.
Thanks very much. I hope those slides are coming through. That's fine, thanks. Yeah, so it's just some examples of using this system that we have at the South London and Maudsley called CRIS, for sort of trying to kind of answer some questions around particularly the first wave of the COVID epidemic, and then sort of where we move from here. So I guess the kind of the sort of impact of the pandemic in mental health care sort of comes in sort of different sort of forms. There's obviously the impact of the direct effects of infection, the sort of risk of infection, severity of infections, and on the background of known pre-existing vulnerabilities in people who use mental health care. For example, the physical health conditions people may have, poverty and other things that people may often have issues with. And then there's obviously the impact of social distancing and lockdown, which we've heard about, worsening of pre-existing isolation, and we've heard Tim talk about sort of domestic abuse, other vulnerabilities. And then there's the impact on the delivery of mental and physical health care, with reconfigured services, staffing shortages, maybe discouraged access. I mean, the issue about sort of people not wanting to come to medical attention because of worries about picking up infections. And that, again, sort of exacerbates pre-existing inequalities. So there's a lot to cover. Sorry about that, some noises at my end. And so this is us at the South London and Maudsley, and for about 12 years ago now, we developed this platform called CRIS, the Clinical Record Interactive Search, which is really just a way of rendering healthcare information from the mental health care record de-identified and available for research, so that we can start answering questions from the information contained there. It was set up with service users fully involved in the security models and everything in terms of the setup and everything. It's been used an awful lot for research. Since then, lots of sort of stuff has come out of it. Of relevance, we've linked CRIS to a number of other information sources. I think for the purposes here, mortality particularly, I'll talk a bit about sort of mortality rates and what we've been able to those. Primary care is a recent, we've recently got sort of updated primary care data that will cover the first wave period, but that we haven't sort of got started on that really, it's only just arrived. Hospitalization data would be great. I mean, that's largely highlighted because it's actually been rather difficult. We got the approvals and everything ages back in May, but trying to find someone at the acute trust side of things who could let us know about sort of and do the necessary data extractions when they're already sort of completely busy with COVID priorities. That's been quite an uphill struggle, so we're still sort of trying to move forward with that. Another particular feature is that we can get a lot more information than would normally be available in a record system through developments we've been working on for a long time with the clinical text in the record. A lot of the most important information about people using mental health care and the issues that they're coming with is recorded in text rather than any sort of tick box or easy to access data. And so we've got quite a lot of that information is now sort of, we can actually use that information to characterize the samples that we deal with. So research is not used to doing things fast, I have to say, as a researcher myself. And one of the sort of challenges early on was actually to try to kind of deliver things in a fast way, whereas research usually sort of mulls over things for a long time, then it sort of sits around waiting for things to be published, and then it sort of gradually sort of tries to get that sort of publicized. Clearly there wasn't time for that, and so one of the big turnarounds, apart from having to work out Teams and Zoom and all the rest of it, and have our whole team suddenly working from all areas of the country rather than being in an office together, was actually how to sort of turn around findings quickly. I'm pleased to say we were able to do that, in that, I mean, these graphs here show some of the early changes up to the end of March. And the blue lines on the sort of left-hand side show the rising mortality already in our service. And the others show some of the changes in service use, so that there was a sort of spike of discharges from inpatient care as we had to kind of clear the beds quite a lot in preparation for both overflow and the difficulties with staff shortages in sort of maintaining the beds that we used to maintain. And then the graph on the sort of bottom right is about sort of home treatment team contacts. And there's a sort of rising orange line there, which is showing the sort of non-face-to-face contacts, and the blue line is showing the face-to-face contacts. So as we've talked about, sort of this huge switchover from face-to-face to virtual contacts, even in something like a home treatment team, which is very urgent sort of crisis care. It's not the sort of, you know, calm, more measured sort of type of care that you'd have in IAPT. So there was enormous challenges early on. One of the things we've learned in trying to kind of sort of get this information out is the deficiencies of the traditional peer review system for research publication, and that sort of by the time we'd sort of got this, tried to kind of get this to sort of relatively easy journals, by the time anyone had looked at it, it was getting out of date. And so we've largely used this site Medrix, which you've seen in sort of some of the other references, for disseminating things, which has really been a matter then of trying to make sure that what we're disseminating doesn't need peer review. We're just trying to get descriptive information out there, not make any, draw any conclusions from it, and just sort of get the information out there for people to make use of as they will. We're able then to kind of plot later changes. So the sort of the top graph there is of the deaths that were experienced in 2020 compared to 2019 this is past and present service users at the South London and Maudsley. So you can see that sort of spike there, and that's sort of, you know, there is around sort of 1,100 excess deaths in 2020 compared to 2019. And again, the sort of bottom graph showing the continuing changes, in this case in home treatment team activity, the caseloads dropping. This is kind of running up to the sort of up to late May, so relatively early on in the first wave, and we're sort of working on trying to get some of that more up to date recently. But going back to the deaths, so are these more than would be expected? Well, there was excess deaths everywhere, and South London got hit by COVID fairly badly in the first wave. But the blue line shows what we experienced at the South London and Maudsley. The orange line is the sort of national excess, how many more, you know, how much higher deaths were in it than would it be expected. And the grey line is the same for London. So you can see that our service users had even more than the sort of London rates in terms of excess deaths. The blue lines do need to be shifted over to the right slightly, because the Public Health England data are measuring slightly a sort of slight delay in their measurement of deaths. But even so, there's quite clearly was the rise in mortality was higher than it should have been, or higher than is observed in the national population. And this is just doing the same but splitting up by age groups, and it's basically to show that it's not just an elderly thing. So although it's there in the older age groups, which you might expect with all the sort of care homes covered in our catchment, it's there also in sort of men 45 to 64, in women 45 to 64. It's higher in our population than it would be in this case nationally. And looking further at that, there are clear ethnic group inequalities, unfortunately, but perhaps, you know, sort of, well, just unfortunately, really, particularly the Black African Caribbean population showing much more of an excess than other ethnic groups. We've subsequently looked at this in sort of a multi-site initiative, where a number of colleagues of mine in other sites around the country were able to do similar extractions from their own local data, both of mortality numbers in their patch, but also of the same sort of healthcare contact sort of information that we're trying to kind of sort of look at in terms of the changes over the first wave and how consistent those have been across sites. This is just some data from mortality, again comparing the mental health trusts with the regional estimates for their patch. Not all sites showed more than their region, but most did. So it didn't seem to be just a South London and Maudsley issue. It was present around in a number of sites where people using mental health services had a sort of higher mortality spike. Recently, we're able to look at causes of death as recorded on the death certificates, and on the graph on the left there you can see the excess. This one here is COVID, so obviously a lot of the excess deaths were as a result of COVID caused infections. And then of the others, there were a couple of spikes for people with sort of dementia coded as an underlying cause of death, and then a slightly worrying spike in sort of unexplained causes. Now, suicide would be included in that, but it might well include other unexplained causes, such as people who are socially isolated and were found dead at home, but with an uncertain cause that's still waiting for coroner's inquests and the like. And thinking about the COVID ones particularly, again, there was an ethnic group inequality. They were higher. The COVID deaths as a proportion were higher in the Black African Caribbean patients compared to the other groups. And this is relatively very, very recent data just that we've just looked at recently, just taking everyone who was alive at the beginning of March from our service user communities and looking at who died of COVID. And in this case, by diagnosis. And this is comparing people with sort of affective disorders, bipolar disorders and depression. That's the sort of reference group. And the high group, so the organic disorders group, which would include people with dementia for obvious reasons, although it's age adjusted, people with schizophrenia and schizophrenia-like disorders and learning disability. So those are the sort of three diagnostic groups that seem to be particularly coming out as relatively high. So that was sort of work on mortality as a sort of example of some of the things that we were able to look at. We've looked at other things, and this was some work looking at people presenting to emergency care and whether the characteristics of emergency care presentations had changed over this period. Again, this is mostly running up to late June. So the red lines are the ones to look at, and they show that's what's happening in 2020 compared to the previous 5 years. And this is in terms of overall numbers. It was relatively high, interestingly, in early 2020, and then it dropped dramatically, which a lot of trusts saw around the early stages of the first wave, and then sort of has risen to relatively high levels. We're sort of at the moment updating that to see what's happened over the summer. But other characteristics, a lot of things haven't changed. So a lot of things like sort of age, gender distributions, all these sorts of things weren't very different in 2020 compared to previous years. Recorded domestic violence was relatively high, particularly this is in the records of people presenting to emergency care. That was relatively high. Loneliness, relatively high, not dramatically so, but recorded loneliness as an issue. And then we were able, again, through using these sort of text processing programs I mentioned, to look at the symptoms that people were presenting with or were being mentioned in emergency care presentations. And a number of depression symptoms dropped quite a lot in the early stages of and remained rather low during the first wave. So there weren't too many people with depression being recorded around that sort of time. And then sort of into June, there was a bit of a spike in people with manic symptoms, essentially with bipolar type disorder sort of type symptoms that might reflect people relapsing around that sort of time. And again, this is information that we're trying to update at the moment to see how things have been more recently. And then finally, we also looked at self-harm, and that a number of sites have been doing this, and there are national initiatives trying to sort of look at the numbers with self-harm presenting over the pandemic periods. Again, this is just the first wave, but again, we saw a sort of quite a drop, although it was actually a drop from before the the official sort of start of lockdown and everything, it was already sort of falling a bit, but it certainly went quite low and then come up again. And I mean, anecdotally from colleagues, it's relatively high now. So I think you can't assume that the second wave is going to be the same as the first wave. It's a very sort of different experience, I think, more recently than it was in those early days. So drawing sort of considerations and everything from this, I think one consideration is there were clear excess numbers of deaths in potentially vulnerable groups. And this has got to be an issue for the second wave, which we don't know so much about at the moment. So, and a worry as COVID, the pandemic, drags on. I think there's the whole issue about, we've heard a lot about sort of how mental health care has changed, and the way it's delivered has changed really dramatically, you know, and you know, completely almost overnight. And we don't really know whether that's a good thing or a bad thing. I suspect it may be good for some people, but it's clearly not good for others. Good in some areas, not good in others. And we urgently need to establish, well, you know, who's benefiting and who's not. And we've got a bit of a chance to go back now to sort of start thinking about how do we continue to deliver care. There are unclear longer term issues. So interestingly, in the causes of death, we didn't see any sort of excess deaths from things like cardiovascular disease or cancer or respiratory disease, but these are longer term things, and if people have been neglecting their physical health, then these are not going to be things you'd see during the first wave. They'll accumulate later on. And so I think that's another longer term issue, is this whole issue about missed morbidity, about understanding, you know, what's going on at general practice levels of people with pre-existing health conditions, and how on earth do you see a GP nowadays is quite difficult for, you know, the best of times. And then we've, as has been talked about, the economic and societal pressures that we're going to face with the recession to come, that's going to be quite important. And I think sort of, this is slightly from my point of view, but I mean, I think there are enormous opportunities for mental health care and the information that's routinely collected. We were able to do this because we had a system called CRIS that updated itself every 24 hours, so it was relatively up to date. But the information is there, and whenever you talk to people about using healthcare records information, there's often a sort of big sigh as people think, oh goodness, it's kind of complicated, isn't it? And it's a shame that it's seen that way, because I think there's an awful lot that where services could be much more responsive if we could just get a better system for getting the information out there quickly in time for services to change and respond to that. I think it's possible because it's there, and these techniques are possible. It's just the impetus and the effort of sort of getting our healthcare system into a position where it can really respond to things as they emerge. And we've tried to do that as researchers, and tried to kind of work faster than we're used to working. And I think it's just a way that things will surely have to change at some point. I do accept that it's a big ask. And that's just my final acknowledgements of all the people who are involved, particularly at the sort of different national sites who are able to collect data. And we hope to have more of that coming out in the weeks and months to come. Thank you very much.
Bob, thank you very, very much. Fantastic presentation. Great use of that data. It's raised lots of questions which have come up in the chat site, and I'm very pleased that Rob's going to be joining a number of other speakers on the panel shortly for a Q&A. And so will Mark Brown, who's our next speaker. So Mark, for those who don't know, is the Development Director of Social Spider Community Interest Company, and is an associate of the National Survivor User Network, and he supports researchers and writes about mental health, social innovation, social media from the perspective of someone who has lived experience of mental health difficulties. And he specialises in projects that bring new perspectives and approaches to mental health and the intersection between social innovation and mental health. I have the great pleasure of seeing Mark speak a number of times, so very pleased to see him again today. Mark, welcome.
Hello, hopefully everyone can hear me at home. Can you hear me? Just someone say yes. Brilliant. So, trying to get through to Alan Gibson, please. Oh, there's some noise in the background there.
Could everyone make sure their mics are switched off, please, other than Mark?
Yeah.
Thank you.
I'm going to crack on. here. Got quite a lot to get through, so I'm going to talk quite quickly. So first of all, there's not really one story to the COVID-19 pandemic. People across the UK and across the world have been experiencing the pandemic in different ways.
Yeah, Chloe's our receptionist. Yeah.
Yeah, someone's got their mic on.
Somebody's talking on phone or something. They've got their mic on. If you could switch it off, please.
Right, I will crack on again. So there's not really one story to the COVID-19 pandemic. People across the UK and across the world have been experiencing the pandemic in different ways, depending on where they are, who they are, the conditions of their lives and communities as they enter the pandemic and the wider context of life and responses to COVID-19 where they are. There's not really one story to tell about how the pandemic's affected mental health or the industries that attempt to preserve, maintain and promote it. The coronavirus pandemic is a novel event. It hasn't happened before. There have been other pandemics in history, but none of them arrived in this time and this place. The issue of mental health, who has it, who does not have it, and who within communities has the capacity to improve it for themselves and others is not fixed and eternal set of conditions. What people choose to use their own experience of difficulty to do, and the means that they arrive at to do so are as varied and vibrant as any other attempt to bring about change within communities. Responses to the COVID-19 pandemic from March onwards suspended many of the normal elements of community and service provision, creating a national situation without a useful parallel. From May onwards, the murder of George Floyd and the subsequent outpouring of anger at racist policies, institutions and attitudes further focused minds on issues of racial inequality and broader structural inequalities. In the background to this, there's the looming spectre of Brexit, a decade of public spending cuts, local authorities with reduced spending power and more rapid changes of Westminster government than the UK is accustomed to. And that's created an already uncertain looking picture for mental health onto which we heap the privations and challenges of a national attempt to stop the spread of a potentially lethal virus, mainly transmitted by one of the most treasured mental health promoting tools we have, which is face-to-face conversation and human contact. The jury's still out on the effect of the pandemic on mental health people. It's clear fewer mental health services were delivered than would have been if the pandemic hadn't happened. No one yet has the single definitive account because events are still unfolding. Normal, or what comes next after normal, hasn't arrived. It's clear to me that eventually the coronavirus pandemic will be the best documented pandemic in history thus far. But for now, everyone's telling what they've seen and what they have observed from their own occluded viewpoint, limited to who and what it was possible to observe. For some of us, for some of us who've been shielding, that's been the view from our own window and the glow of our screens. For others, it's been flows of data. For others still, it's been the experience of others that we could bring together or the outcomes that we can measure. Right now, we can only really share what we've witnessed. Throughout the pandemic, I've been working with the National Survivor User Network, NSUN, a network of people with lived experience of mental ill health, distress and trauma, and organisations led by people who've lived with or are living with the same. The concept of user-led mental health organisations has a long and varied history, encompassing everything from pressure groups to self-help activity to peer support to charitable service delivery. NSUN's membership includes organisations that fall into all of those categories and more besides. Between April and July 2020, the NSUN COVID Fund distributed £120,000 to 88 user-led groups and organisations in England to support them in carrying out activities to support others' mental health during the social distancing lockdown and beyond. The initial £60,000 was made available from the Department of Health and Social Care via the Coronavirus Mental Health Response Fund. Further additional funds of £50,000 were released from the same fund and were distributed to 10 organisations as part of efforts to support organisations and groups that served and came from racialised communities. And Lankelly Chase also stuck in an extra 10 grand to that. 63% of the funding from the NSUN COVID Fund went to groups led by people from racialised communities. Due to the need to distribute funds quickly, NSUN cast its net widely in advertising the funds, which led to applications from organisations and groups that would not have necessarily described themselves as user-led mental health organisations, but who were certainly carrying out activities that supported people's mental health and were certainly led by people who had experienced mental ill health themselves. The stipulations for the fund were fairly simple. 1, you had to be user-led. 2, you had to have a specific idea for how you would spend the funds you were asking for to help others' mental health. 3, You had to spend the money to help people right now, or as near to now as possible. 4, the maximum available grant initially was £2,000. 5, you had to tell us what happened and how you spent the money. The process of application began with a short form. After an initial sift, applications were passed on to an Ensign associate who followed up with phone, Zoom, or email. In combination with the initial application, a short written recommendation with additional background for the funding panel was created, and a shortlist was created from that. These shortlist recommendations were discussed by a funding panel made up of Ensign trustees and associates, which included me. People applying didn't need to have a bank account, didn't need to be anything apart from an unconstituted group. The whole point of the fund was to get small amounts of cash out to people with lived experience of mental health difficulty doing stuff right now. What we found from our applications was that people with lived experience were doing a number of different things across England to look after each other's mental health. Applications came from across the spectrum of different types of organisation, everything from unconstituted mutual aid style groups to small charities to social enterprises. The problems that people were trying to solve weren't the problems that the NHS was trying to solve, nor were they trying to replace the things that the NHS was struggling to provide. It can't be said too often that the NHS is not the sum of mental health or the only mechanism that influences people's own mental health, no matter how vital services and treatments are. Roughly speaking, successful applications fell into about 8 categories. I'm going to go through them one by one. So first one's money to use technology to keep in touch. Far and away, the most commonly funded thing was a Zoom or other video conference license to better enable the holding of online sessions, discussions or similar. Also in this category were funds to purchase things like cheap tablet computers or laptops, either so a group itself could use them for video conferencing and social media, or so that it could be distributed to people who didn't have that technology. Similarly, money for data, so that they could actually connect with the internet in the first place. Second thing was things to distribute. Craft materials and activities were popular things, as were things like PPE, masks and sanitizers and the information to go with them. At least one applicant used funds to make a newspaper stroke magazine to pop through people's doors when they couldn't see them. Third thing was the booking of outside facilitators to run online sessions. Groups recognising that they didn't really know how to offer things that people were missing, booked outside facilitators, trainers or sessional workers to offer sessions online. The fourth thing was money for petrol / money for mobiles. Groups asked for small amounts of funds to pay for socially distanced visits and to pay for phone bills so that they could telephone people. Fifth thing was the launching of new online things. Overlapping with the paying of outside facilitators, people asked for funds to help them to set up new online things, either as substitutes for things they've been doing prior to the pandemic that it would have been doing face-to-face, or taking the opportunity to launch something completely new which they felt would reach people who need the thing they were offering. Some of that paid for things like Facebook ads and similar to draw new people in. Sixth thing, making radio for audiences for whom English isn't their first language around mental health, or other broadcast radio. Just going to take a quick mouthful of stuff. Seventh thing that the applications were about were other practical stuff. And in some ways, this is kind of one of the most exciting bits. One group who supported women leaving abusive relationships asked for money to help pay for their storage lockup for a couple of months so they could store clothes and furniture to distribute to people leaving their homes and possessions behind. Another was setting up helpline for LGBTQ plus people in the traveller community, set up by someone from that community. The Ensign COVID Fund didn't fund food deliveries, but many groups included that in their request. Practical deliveries of things like toiletries happened, added informal problem solving over distance around things like benefits and access to other services. And the eighth and final thing was general access to technology for the purpose of moving to remote working and online activity. People put in applications with very specific bits of tech, hardware or software to make it easier or more effective for them to work online with the existing communities they knew. So that was the kind of stuff that got funded through this, and it's the kind of things that people look for. So what does it mean? What we found was There was an amazing range of people doing stuff that related to the mental health of others across England, and that many new groups and organisations became known to us through the process of providing access to small specific amounts of funds for defined purposes, little things at the right time, supported with few strings attached. Ensign is evaluating how the fund went, and we'll have more to say about that in the future. But my observations were that about 3 things were happening. One, groups of people were looking at ways they could keep together their communities of peers for mutual support when face-to-face meetings weren't possible. You call that kind of keeping in touch. The second thing was people were looking to provide support or other practical things to people they knew would be experiencing a gap or lack of service more generally. You could call that helping each other out. And the third thing was people were looking to create new online things that would reach people they may not have known already. You could call this taking the opportunity to fill the vacuum. Some of the applications were from organisations who already provided a service which was user or peer-led to others in their wider community. These organisations were experiencing intense disruption to their plans for the year and did not have funds available to make the adaptations needed to offer things online or through other means. Other applications were from groups trying to keep their community together until the time came when it was possible for them to meet face-to-face again. Others were taking what had worked offline and translating it into online spaces. These had more of a focus on outreach digitally, and sometimes found that the profile of the people they were connecting with online was very, very different from those they had previously been together with offline prior to the pandemic. Online, it might be easier to attract interested people from around the world, but much harder to attract someone from your hometown. More applications than you might expect came from under the radar groups who were not registered charities, falling more under the banner of mutual aid as peer support than they did under any other sort of heading. People getting together to sort stuff out who had been getting together to sort stuff out before the pandemic began. Groups across the country have been raising and distributing funds to meet essential needs without any recourse to anyone else. People have been getting on with doing things that other people can't or won't do. For Ensign, the language of things like mutual aid helped to define a form of user-led group or activity that worked to their own ends within their own community without subscribing to ideas, practices, or worldviews propagated by statutory or large charity bodies. This autonomous mental health action, led by people's lived experience and meeting immediate and vital needs, focused on building community and meeting community aims first on its own terms, which is something that previously flown under the radar of wider mental health discussion, because it's just people getting on with stuff, not just advocating for other people to get on with stuff. That's an area where I've been exploring stuff for Ensign this year, so I've got a bit of research stuff coming out about that soon. The final we saw was that groups we might have expected to put in applications didn't. Some groups know that, waiting out the lockdowns and social distancing, when people are in touch with each other or help. But people also know that community action can only do so much when government policy, statutory and charity services can't or won't provide the things that people need. They need those services and support to step up too. At Ensign, we've been learning and speaking to people and marvelling at everything people who live with mental ill health, distress and trauma have been doing to help each other through this pandemic. People have turned up, they've put their time and resources where their mouths are, and solved problems that could only be solved by them as best they could in their particular situation. So that's the story that we've seen. It's not the only story, but it's a story that you might have missed, and I think it's one that needs to be recognised. Thank you.
Absolutely. Thank you very much, Mark. Great stuff.
I will also say that I went through that very, very quickly, but I will be getting that online within the hour, so you can go to the hashtag for this event on Twitter and you'll be able to read it and marvel at all of my terrible grammar and awful metaphors.
What was that hashtag again, Mark?
I can't remember the hashtag.
Okay, we'll look out for it. Maybe, yeah, good. We'll circulate it. We can tweet it along with you. Great stuff. So I'm very pleased to say that Mark, Rob Stewart are going to join a few other people on a panel. So we've got Raza Griffiths, who's one of our lived experience researchers from the Mental Health Policy Research Unit, Sonia Johnson, who's the director from UCL of the Mental Health PRU, and a good friend of ours, Helen Gilbert, who's a fantastic researcher and person in her own right from the King's Fund. So very pleased to see that Helen's going to be joining us. Now, we've got about 100 people watching in here, and so it's going to be a bit hard for me to spot people putting their hands up. But I have a load of questions that I've pulled together from the chat during those presentations. So I'm going to kick off with 3 of those, if I may. So the first one, there's about 4 or 5 people who have raised the issues
Sorry
of...
to interrupt you, Adam. Sorry to interrupt you, Adam. I think we've gotten confused with the Q&A for the presentations and the panel that we have later on.
Oh, sorry. Am I not doing this now?
This is being chaired by Bryn, I think, this section.
Sorry. Okay.
So, yeah, no, sorry. We have a panel discussion that you've been mentioning later after the breakout rooms. We had a brief Q&A session now, but I think we've kind of eaten up the time for that, but we're just running a few minutes late. So I think the next thing on the agenda, if people could save their questions, either post them in the chat so you don't lose them, or save them for the panel discussion. But I think Sonia talking briefly about the next bits of work we're doing in the PRU on remote working during and after the pandemic is next, and then we'll do the breakout rooms and then the panel discussion.
Apologies, I was looking at the wrong bit of the list.
Okay, I'm taking it forward then. I'm Sonia Johnson. I'm Director of the Mental Health Policy Research Unit. And I'm just going to add a little bit to the previous presentations that's about the thing we're more focusing on now, which is telemental health. So the use of video, phone calls, text messages, whatever else, to provide mental health care during the pandemic. And this is what's become the major focus for our ongoing work on COVID and its impact. And I'm just going to kind of summarize for you in a small number of minutes where we are with this and what we think might be some important remaining questions. And I hope that this might help stimulate some of the breakout room discussion. So far, we've collected some data from staff about their views about remote working. The second phase of our qualitative interview study that Carrie was talking about has had a particular focus on this. So we're analysing data from that. We've carried out a particular type of review called an umbrella review, which is a sort of meta review, a systematic review of systematic reviews to find out what the scientific literature before the pandemic said about remote working, about telemental health and how well it works. And we're now trying to look at what's been published during the pandemic period on this topic and to bring it together. So just a sort of very brief overview of how it looks at the moment. So pros, I mean, perhaps the biggest one is that it's meant there's been some kinds of care where otherwise there would be none for some people in the pandemic period. But I think people have discovered or been reminded of some other advantages. It seems to make services more accessible for some people, particularly for a variety of reasons. They find it harder to travel. It's efficient and time saving, and actually that's particularly perhaps been where it connects staff. So we've found, for instance, it's easy to drop into the crisis team meeting if you're in the early intervention service, or to have 10 minutes with the ward staff, because it makes staff connecting with each other quite a bit more flexible, sometimes saves travel, reduces environmental impact. some people seem essentially comfortable with it, and sometimes to have found new forms of interaction, new forms of support. And perhaps that's particularly the case with some of the new online support groups that have been set up, either informally or through services, through NHS and voluntary sector services. But some very significant downsides as well. Obviously, digital exclusion, people who can't connect this way, it exacerbates inequalities. It may make it harder for problems to be assessed. It may make reasonable therapeutic relationships harder to form, especially where they don't exist already. Their technology can be a barrier in all sorts of ways, either at getting the right platforms, getting access to them where people don't know how to use them. And I think it's been very obvious that there are huge variations on the provider side in how much both organisations and individual staff are confident enough and willing to engage with these new technologies in providing care, and also that individuals feel very differently about taking this up. It seems to be a very individual thing. Privacy, having enough privacy is very important and not always possible. Confidentiality can raise some different challenges. Wondering what's happened to your data or information can raise some new challenges. And some people seem to experience it as pretty alienating, as intrusive. We're realizing that really people experience it in very varying ways that aren't necessarily to do with any characteristics, but just with how they feel about communicating in these ways. As I've said, we've just concluded and published in preprint form this umbrella review, and we found that pre-COVID, there were 19 systematic reviews on various different aspects of telemental health, and findings included people finding similar outcomes for care by telemental health, finding that it could be quite effective and quite acceptable. I think it suggests basically that remote working can work well, that these kind of appointments can be quite effective and acceptable. What's striking though is that this literature is almost always all covers fairly small studies with people who've made a choice to participate in the study. So it's not sudden massive scale implementation. It's selected people saying, yes, I'll be in that study. That sounds all right. And it seems as if under those circumstances, it can be all right. So from where we are, we're thinking some of the kind of questions are, what does work best for which people, and how do you decide that if telemental health is going to be implemented in future? What sort of guidance, training and resources will staff need to be able to use these approaches as effectively as possible in those contexts where they are useful? Who gets excluded by this, and what does it mean for them when telemental health is being adopted in the system? And how could this be improved? Are there innovations that could make the quality better? Are there innovations that could improve the reach of these kinds of interventions in the NHS and beyond? So that's kind of where we are in thinking about this currently. Okay, I think I'm handing back to Bryn.
Okay. I'm going to have another go at screen sharing and see if it works better for me this time. Yay, good. Okay, so hi everyone, thank you all. So the next point is the bit where we get to hear from all of you. So thank you for all the great discussion and questions in the chat so far. But the next bit is to break out into 6 groups. And these are kind of themed. And I know when you registered, you were asked to sort of select your preferences to which group you'd be in. We can't promise you'll all be in your first choice group because we've tried to sort of keep the numbers roughly even, but hopefully it'll be one where you feel you have an interest and things to contribute. So in these groups, we're going to spend about 20 minutes thinking about what we think some of the most important questions are for kind of future research about the kind of impact on COVID on mental health care and people using mental health services. So that'll be a group discussion facilitated by one of the PRU team who will kind of take some notes of the discussion. We'll save the chat and also record the whole discussion. So this will also be recorded and we'll capture it. And we'll try and agree within the group a small number of kind of priority questions in the sort of topic area that we're considering. So we've got limited time and big groups as ever, so we'll have to try and just all be considerate and give each other a chance to speak. And if you don't get in there, please do use the chat to post ideas and we'll keep hold of that as well. So after that, we'll come back for a kind of the panel discussion and the next parts of the event. So if you need a comfort break, this is a natural break to take one, but please come back to the group and we'll put everyone into their groups now. Thank you. Hi, everybody. Hi, welcome back. Lovely to see everyone. Okay, so certainly our group, we had lots of rich discussion and tons of notes about really good questions and issues to consider, which we will try and collate all of those and put a sort of report out there, make it accessible. So we'll try not to lose all these great ideas. We'll beaver away about trying to get a few of those, if we can, into our kind of prioritization poll, which will be the last thing. So to give some of the team a chance to do that, amongst other things, and to give you a chance to talk to the people who have given us these great presentations today, we're going to have the panel discussion now. So welcome back to Rob Stewart, to Mark Brown, and to Sonia Johnson, who are going to talk, and welcome to Raza Griffiths and Helen Gilbert, who are going to join the panel. So just so that you get to sort of meet Raza and Helen and know where they're coming from before we start sort of questions from the panel, I'm going to just invite them each one after the other to briefly sort of give an initial comment on what we've heard and what they've been doing. So Raza, hi.
Hello
really nice
there.
Yeah.
Hi, thank you, Bryn. I must admit I'm feeling incredibly exhausted, and I think that's one of the kind of disadvantages. It's lovely to be able to see all you people, but I'm feeling very, very exhausted, and I've been eating some frozen banana because of my low potassium levels. That's why I've been eating. But anyway, I'm a mental health service user and campaigner for many years. I know many of the people here. It's lovely to see you. So I was particularly involved in the staff survey of the impact of the pandemic on mental health care staff, and also the international synthesis on the impacts of COVID. So those are the two main projects that I've been involved in at the Mental Health Policy Research Unit. So I've been reflecting on some of this, plus my own experiences. And in terms of priorities and themes for future mental health research, these are some of the things that I think are priorities. So the first one is the intersection of physical health care with mental health care. One has to remember that mental health service users have very high morbidity, more physical illnesses than in the general population. So of course, during this pandemic time, there has been a loss of access, in some cases, complete loss of access to many aspects of physical health care. So you have to take both those things into consideration when looking at the overall well-being. I mean, of course, physical ill health often has an impact on mental ill health as well. So that's a really important intersection that we need to explore more carefully. The second intersection is of mental health diagnosis and ethnicity. I mean, I think it's particularly striking that at a time of profound social focus on issues of racial inequality, systemic racism, and all the rest of it, the staff survey, which interviewed more than 2,000, mental health staff, and you have to remember that BAME communities are overrepresented in the workforce, hugely overrepresented, and also hugely overrepresented in the mortality statistics. BAME nurses are particularly prone to dying. So given these three factors, why were less than 10% of the sample from BAME communities? And I don't ask that in an accusatory fashion, but I think we need to pause and reflect on that. Is it a lack of engagement generally? Is it a lack of trust? I mean, if that is the case, and I don't think we've established why, there may be other reasons, I think that very much reflects the kind of disengagement of BAME communities, BAME activists and service users from trying to kind of engage with the system and improve it and getting our voice heard and making a difference. So those are the two intersections. I think a third issue of concern to all communities is the therapeutic environment or lack of it. Because what we know is that we're starting from baseline, particularly on inpatient wards, where there's often a lack of a therapeutic relationship. The culture on wards is one of them and us. And of course, the very massive issues of the use of detention and control and force have always been there. And my question is, has this increased as a result of the kind of hothouse conditions that we're all living in and having to kind of keep separate from others? And, you know, does this lead to increased anger and frustration on inpatient wards, which may result in more use of force and control? It's a question, and I think we need to investigate it, particularly because more recently, you know, there was the Mental Health Act review, which arguably didn't do very much around those key issues. Also, wider developments such as the United Nations Convention on the Rights of Persons with Disabilities, which is widely kind of interpreted, including by the United Nations, as, you know, that we need to move away from force and control and the rest of it, but has the pandemic kind of taken us in the other direction? So the other issue which we need to really look at is the kind of differential impacts of COVID, you know, on the population, and what are the factors that disadvantage people disproportionately? You know, are existing inequalities being reinforced, you know, in terms of poverty, in terms of, you know, if you're a single parent, for example, how accessible is online therapy if you're a single parent, if you don't have a sense of privacy in your own home, if you're in an abusive relationship, is it a safe environment? So, you know, we need to look very carefully at how different groups are differentially affected and try and ensure, I mean, I'm guessing we're all in favour of equal access and kind of equality and all the rest of it, to ensure that the services and support that are emerging out of this crisis are kind of equally accessible and equally beneficial to everyone.
Raza, that's fantastic. I'm sorry to cut you off in mid-flow. I'm slightly conscious.
Just one very quick thing, which is that the speed, the rapidity of change that's been forced on the system and the way the system has risen to that, I think this signals the capacity of the system to change quicker than we sometimes give it credit for, you know, because there's so many things that we've been pressing for, wanting to change, and constantly told, oh, you know, we need to move at a snail's pace, or we haven't got the resources, etc. But I think this is a counter argument potentially to that argument.
Fantastic, thank you. There's a real agenda there, isn't there, which people may want to pick up. Just before we get to some sort of questions from the audience, Helen Gilbert, hello. We're really glad to welcome you to this event from the King's Fund. And I don't know if you'd like to give us a sort of brief opening gambit for things that are really important, perhaps from a sort of policy perspective in particular.
Yeah, so hi everybody, I'm Helen Gilbert from the King's Fund, and I guess there's a few things I've said in the breakout as well and been picked up. I mean, the first thing really is this is a huge, massive experiment, you know, over very short period of time, things have changed absolutely massively. And I would, you know, advocate that we've effectively got a brand new baseline of where we can work from. And I think there's an opportunity to look across not just areas such as telehealth, which is brand new and is, you know, it's infiltrated so pretty much the whole of the service now, but also the changes that have happened on wards in different merging and changing of services. And there's a real opportunity to tell us, to think about what does that actually now tell us about how care was, you know, if we've had to close wards because they weren't, you can't control infections, or we've had to change staffing and availability. And what does that also tell us about how care needs to be in the future? I think there's a real push at the moment for what can be done, and I would advocate very strongly for also having a very strong focus on quality of what the quality of care is as a consequence of some of the changes and where that needs to be. Quality has been an ongoing problem for quite a few years in mental health services, and I think it needs to be a forefront, not just of access, but also that we provide good and effective quality care. I'd advocate that mental health provision is not just provided in mental health services. Primary care services, increasingly we're doing work with them, and there's a big programme of work to try to join up primary care mental health with secondary care. And one of the big findings of that is actually, although primary care mental health is the point of access often for people with mild to moderate symptoms, actually they hold increasingly large numbers of people who have experienced secondary mental health services and continue to receive care. So, you know, I'd advocate again that we look at that area. Two more points. The first is there's limited resource, although there's new resource coming in at the moment, but we need to think more about, not just about more service or more things that we can add into the system, but how we use what we've already got that's better for people. So how we make that works better for the people we're trying to support. And the final one I say is about workforce wellbeing. So mental health services, the National Staff Survey for a long period of time, mental health services comes second from the bottom. So at the bottom we've got staff wellbeing is poorest in ambulance services, and then it's mental health services. And it feels like some things have shifted during this period just really to keep staff going. So there feels like there's a piece of work to understand actually what does staff wellbeing look like in mental health services that's going to be really fundamental for recruitment and retention, because staffing is a key issue. So those are my sort of top advocate for.
Lovely, thank you, Helen. That's another great series to take forward. Okay, so we now have a little brief time, and I believe Alan has been sort of trying to look at the chat and has got some questions that pick out some of the themes that have been coming out through the day, which can be addressed to all 5 of our panelists really to chip in as they see fit.
So there's been all sorts of questions, and I've tried to group some together, composite questions. So I'm going to kick off with one which has been a feature in a number of the chat entries. People like Tamar James, Tina Colden, Peggy Malongo, Alison Faulkner have all been asked around issues around Black, Asian, minority, ethnic communities and the impact of COVID and the impact on their mental health services. So a sort of a combination question really is there, or why is there limited evidence about the perspectives of people from those communities in a lot of the work that's been undertaken? Are there, or should there be more appropriate treatment interventions for Black, Asian, minority, ethnic patients in the community? And given that Black, Asian, minority people seem to be more affected by the impact of COVID, and certainly if they have mental health problems as well, should they be a priority for vaccination and improve access for physical care in mental health services? So a nice little combination, but the issues around Black, Asian, minority, and ethnic communities. Nice, easy one to start with.
Mark, I see you coming in.
Mark, thank you.
Well, like to me, on some level, it's really obvious. The problem is everyone's freaking white in research, more or less.
Yeah.
And the pipeline between wanting to do some research and getting people to pay attention to you as a researcher is very long and requires a lot of resources and investment that you may not have access to. You know, so it's a very obvious point to make, but just in the way that charity is so white, research is so white. And if we're talking about all these issues around race and ethnicity and stuff like that, there needs to be some people giving up their space in wanging on and making space for other people to have the opportunity to wang on. And you know, that's the simple thing. Yeah, I just, you know, I can't tell you what a Black and minority ethnic community, a community in any of the places across the UK needs or wants or really wants to find out, or what's really affecting them. We need to find mechanisms by which we can just let people get on with it and do a good job of it.
Thank you, Mark. Anyone else on the panel? Sonia, please.
Yeah, I'd say, I mean, Andre's just posted a link to a recent mental health question time that I think covers this whole issue of inclusion in research extremely well. And I'd recommend looking at that. Just to say, although we were very disappointed by our staff survey, despite various attempts at networking with relevant organisations, and we still ended up with only 80-something%, only a bit under 90% non-white staff. We did do somewhat better than that in the interview study, the service user interview study that people have talked about, where I think only 50-something% were white British, and there was rather better minority representation. And that was really because particularly Josephine Ocklew, who works with you, Alan, and a couple of other people in the group made just huge efforts to pursue all sorts of voluntary sector avenues to really find all sorts of innovative strategies for getting a somewhat more diverse sample, thus showing that if you're the right person with the right connections, you can get somewhere with that. And I think
increasingly now with the whole Black Lives Matter movement and everything, that I think universities are really starting to look at themselves and think about, what do we do? I know at King's we've been doing a lot of the work the last few months of trying to think about how do we bring in and promote and support more Black, Asian, minority members of staff, and it is a big issue, isn't it? It's about having credibility with those organisations when we go to them. Otherwise, it feels very exploitative. Anyone else want to chip in on that question before we move on? Rosa, yep.
I just want to say that I wasn't involved directly in the interviews and sampling all that for the survey. I mean, were there no BAME staff, NHS staff networks that could have been, were they approached?
Yes, we were approached, lots.
Yeah, and we use targeted publicity and so on and so forth. But there is quite a literature around why some of the arguments of why perhaps people don't come forward and don't respond. And a lot of it is about previously feeling their voices have not been heard and not been responded to. And I think that's a good point. If you don't feel anyone's going to change anything, you stop bothering. And I think we've got to engage with that issue. It's a real issue. Should we move on to the next question? Thank you. Alison Faulkner, I think this is a good question for everyone involved in these research that's been going on, different types of research. Are there any concerns about the validity and the ethics and the quality of this research that's all been conducted at some speed? Obviously not.
Oh, shall I go?
Go on, Sonia. Go on.
I think there's necessarily a balance between what you can do very quickly and what you would like to do if you had longer to set things up. For instance, looking at a sort of wider range of channels for recruitment and recruiting through the NHS, which was not really feasible in the time available. I mean, I guess I'd say that I hoped that using a sort of co-production approach meant that we got a lot of good advice and good inputs into trying to work quickly on it, and that an awful lot of different people with different perspectives, both staff and service users, had inputs to the study, and that was very helpful. We also did have, I think, full ethical approvals, at least from university committees, which were able to scrutinise what we were doing at speed in a way that isn't normally possible, and at the moment is only possible if you do COVID research. Actually, everything else is slowed down, but that gets considered quickly.
I think as well on the ethics, I think there were certainly in our team, there were an awful lot of discussions around the ethics of what we were doing and the sensitivity of some of the work, and a lot of thought put into how it was done. And I don't think these things are done without that consideration, but no doubt some things could be improved. Does anyone else want to come in on that issue, Speed? Rob?
I can say, yeah. I mean, in terms of ethics, I mean, what I was presenting was covered with existing pre-COVID frameworks. It was anonymised information. so we didn't have to apply for anything new. We tried to assemble a specific service user advisory group as quickly as we could. I think we probably could have done it quicker, but we managed to get one in order to kind of sort of make sure there was co-production and sort of a decent amount of input into what was being done of a COVID-related nature. In terms of the quality, I think there's a tricky balance with the peer review system. The peer review system just doesn't work for getting information out there quickly. As I say, we managed to turn around a paper in April, publishing on sort of data that was emerging up to March. We got 1 or 2 peer reviews that were nothing to do with the quality, just to do with we don't think this is interesting. And by the time we'd gone through that process, the data was out of date. So what was the point of that? So I'm a great believer in the ideal peer review system, but I just don't think it works for a situation like this, in which case, yes, you have to put things out there and hope that they're as good as possible in the absence of peer review. What we did was try to put information out there that was blindingly obvious what we did, as in it didn't involve anything sort of complicated. It's just straight descriptive data. Look, here's the South London and Maudsley, this is what we found. We're not saying anything more than that. Take it, that's just what we found. We didn't make anything extra from it. So, but I don't think the world has sorted itself out on this.
No. Mark, thank you, Rob. Mark.
Yeah, I was just going to say that in some respects, the question here is what is the jeopardy involved in getting it wrong or doing it badly? Like thinking about research, there's all the stuff about ethics, all the stuff about safeguarding and making sure peer review and stuff like that. But really, it comes down to what will happen in the world, or what potentially will happen in the world if you cock it up. And I think that's the thing. The moving at pace stuff really makes me think about, because unlike research in normal situations, the research is actually being acted on and shifting public debates in real time as it's published. No one's having a chance to sit on it, no one's having a chance to scrutinise it, no one's having a chance to synthesise it, or at least not in the same places that the discussion's happening. And I think that's why you have to be really, really careful. Like, who might use this badly and what might they do because of it?
There's also, of course, a price to be paid for no research and no evidence. And certainly with the PRU, our feeling was that in the sort of, at least in the kind of research that's in the scientific literature, mental health services and people with pre-existing conditions weren't really becoming part of the discussion or being looked at. So there's an important price for if there isn't any evidence around.
Absolutely. Absolutely. Helen, did you want to add anything to that?
No, I think Sonia's just picked up that.
Yeah.
I mean, coming from a policy perspective, everything was changing on a daily, weekly basis. So actually, some of the papers that you put out, for all the flaws they've got, gave us a position of actually what's happening at scale across the country. And I think even research that's not, setting a ground mark of, this is the gold standard quality of what we know of what we should do and implement, actually, while a lot of the research at the moment is sort of just capturing what's happening. I think it's almost like we're not starting from a standing point, it's already happening, and if you don't research it, it's going to happen anyway. So it's better to try and influence the direction and also know where to roll back on some of the things that have already happened.
Yeah, I agree. I think it's a little bit like the swift changes in service delivery. There's been swift changes in research delivery as well, and many positives with that. But also we need to be alert to the safeguards that are there for good reasons, because of historic abuses, and we need to be mindful of that and to be cautious. But probably it has changed the way we think about how we do research, and that's probably been a good thing. I'm going to move it on to another question. There were quite a number of questions from different people, not least Ben, I've lost his surname, Glass, who were asking about what seemed to be a disproportionate impact of COVID on people with learning disabilities, with autism, and particularly people in perhaps longer care, institutional care. And any thoughts about that? Because I'm not quite sure how much our research focused on that, but or other people's. But any particular thoughts around that, the challenges of doing research in those areas?
I guess as much to say that this is almost like COVID more than anything has highlighted the huge inequalities in society. And this is a group of people, particularly those who are institutionalized, where actually national policy and services themselves have done really badly by. And I think again, this is, it's not unique to COVID, but COVID's really highlighted that this is a group of people, very much what's happened to people with learning disabilities and autism, and those people, particularly in institutions, is really reflective of what's happened in the wider care sector, as opposed to what happens in mental health services. And there's been a strong sort of sense of this group within the mental health world has been out of sight and out of mind quite a lot. And so I think the more that we can do to see them as part of, as a bigger picture and highlight the particular inequalities that these groups of people have experienced as part of that, the more we'll be able to move things forward.
Yeah, I'm aware that colleagues of mine in Florence Nightingale Faculty of Nursing are doing research in care homes around the impact on staff and on residents, but particularly people with dementia rather than learning disabilities. And I do think that's often a group population in our communities which are underserved, as you say, Helen, probably reflecting some wider prejudices that are going on.
Just to highlight that there is a paper that our colleagues wrote with data from our staff surveys, and they're reporting the perspectives of people who work with people with intellectual disabilities. So I think it's worth looking at that just for a start.
Absolutely. Is there anyone watching in that would like to ask a question? I can try and see hands going up. It might be quite a challenge. Or if you want to switch your mic on and just shout, you're dying to ask a question. Do you want to jump in?
Hi, Alan. It's Duncan Tree. I did throw something in the chat on Brian's suggestion, but I just think it's a plea that we widen the lens on what we understand as the workforce. If you only look at the NHS mental health workforce, then you'll only get a limited perspective on what their needs are and their challenges as around things like, in the group chat, we had a helpful discussion around unpacking what we mean by equality, diversity and inclusion. But I think it's quite clear we need to start unpacking that and start talking about race and racism. People who experience racism in the NHS may have a different experience than those that understand and engage with it in the voluntary and community sector, mental health sector. Equally, social care has got a critical role around mental health beyond just the AMP role. So I think the workforce is three-tiered. The VCSC and local authority workforce hasn't enjoyed the COVID collapse and on street corners that the NHS has, and I think that speaks to part of the problem. Equally, that speaks to the issue about where people present when they're in need. And increasingly, people don't go to the NHS. Well, in many instances. So if we're going to understand, interrogate and respond to needs, we need to understand where people present to. And the report in HSJ this week that Helen helpfully flagged, ostensibly on the back of research by NHS England, that said there'd been a 40% surge in demand for services. Well, mental health services. Well, how do we know that? What is that demand premised on? People presenting to the NHS? If it's just the NHS, how accurate is it? What's the nature of that demand? What's the severity and what the needs are? So I guess my plea is we need to, if we're going to to mental illness, mental health and well-being, we need to unpack where people present to, where the workforce is, and respond accordingly, because it's far more than just the NHS. And in fact, if you look at the community mental health framework for adults and older adults, the investment capacity in the VCSE is all premised on investment by local government at this stage, not the NHS.
Thank you, Duncan.
Just to say, I totally agree with those points. We actually did include the whole mental health workforce in the survey that we did, although I think the coverage was variable depending where we could publicise it and get in, but it did include voluntary sector, community organisations, social care, as well as NHS.
I've got a couple of people with some more questions, but I think we'll probably need to wind up quite soon. Jennifer French, I see you'd like to ask a question.
Yeah, it's just in response really to what was just said by Helen. Oh, can you hear me?
Yeah.
Oh, yeah. Right. Yeah. this today has been fantastic. I just need to say I've really enjoyed it, and it's been very, very informative. The big question in my mind is, we've heard people talk about, should we bring primary and secondary mental health care together? And we're talking about mental health and well-being. And I think the whole issue is getting very confusing, and I think it's to the detriment of our most vulnerable people, those people who are in our secure services, people who we've already talked about with dementia. Where should we be focusing our secondary mental health services? And surely our third sector colleagues and all those other people around in the primary healthcare services that should be dealing with, when people are saying, there's going to be a demand on mental health services, what do they mean? And my biggest concern is our most complex people are going to be forgotten in this, and they're going to be lost. And we have only got a limited resource. As a mental health nurse, I know how limited we are, and we need to be focusing on where our skills and knowledge are most needed. That's just my thoughts.
Thank you, Jennifer. Thanks for chipping in. I think we're gonna. We've lost Rob and we've lost Sonia. Both had to go for other appointments, unfortunately. So I think, are we ready to go back for our poll? I'm looking for this. Yes, we are. Okay, so thank you very much for everyone for your questions. Sorry for those who I haven't got to. Stephanie in particular, I see your hand up. Apologies for that. Thank you for everyone who's taken part, and we'll now go back to look at our priorities for our research. Thank you.
Sorry. Okay. So this is a priorities poll that we are running to ask what are the priorities for future research. This is a Mentimeter poll, and the way, for anyone that hasn't used a Mentimeter before, you can do this on your phone or you can do it on a browser on your computer. And you just go to menti.com, you type in the code, which is this code here. So menti.com, and you put in the code and you press submit, and you'll be given different options to pick. And we'd ask you to pick the top three for you, like what you think are the sort of top three priorities for research. And when you pick them, you can then reorganize the order, so you can pick what order they should be in as well, using these 6 little dots, and then just press submit, and we'll get the results through. So the go to menti.com and the code is there.
How long have we got to do this, Luke?
Got about how long do you think? About five minutes?
Minus 5 minutes. Yeah.
I can run through the options. I can read them out while people are getting on with voting.
Yeah, let's do that.
So the first one is, how has the accessibility of services been affected? And what are the barriers to use for marginalized and minority groups? The second one, what is the impact of COVID-19 on needs for community mental health care, including acute and crisis care, and how to meet these? Thirdly, what is the impact of the pandemic on inpatient care and Mental Health Act use, and what strategies are there for managing these? They're all moving around. The fact they're all moving around has meant that I've kind of lost where I was.
Yeah.
But never mind.
Maybe people are going to read them themselves. Let's give it a few more minutes.
Yeah.
Alan?
Yes.
Just to say that there's several people saying in the chat column that they're not tech savvy enough to be able to follow this. They maybe need some more time to process and everything.
Yeah.
Or could somebody explain it in layperson's terms? I like the colours myself.
So if you are able to access a browser like Safari or Chrome or whatever, you just type in menti.com
Yeah.
And then you have to put in the number, which is, I've lost it.
So like this.
7507263. 7507263. And then you get your list of options, and the idea is to pick them in the order you wish. If you only want to do 3 or 4 of them as your top 4, you can do that. You don't have to do them all. You've got to open it again, Luke, for voting. It's been shut.
Okay.
Thank you. Luke, there's a question from Jackie Lavelle saying, how were these categories decided? And can we take more time? But would you like to say a little bit about how they're decided?
Sure. So when everybody registered, people were asked to say what they thought were important questions for us to, well, for the research community to consider. So we looked at those questions and we tried to group them into about 7 or 8 different sort of broad questions. And then during the breakout rooms, we looked for anything that was additional to what we already had, or anything that didn't fit into the questions we already had, and tried to group those as well.
Okay, so we'll give it another 30 seconds. It looks like it's slowing down now.
Yeah, we've got nearly 30 responses in.
So it's worth saying this is a great exercise, and we'll be making use of this. But also, we've got all the chat that's happened today, all the comments have been there. We've been recording all the discussions, and in the breakout rooms, we'll be looking at all of that information and collating that and making sense of it to inform our research, and certainly, I'm sure, publicising it to inform others. Okay, I think we're coming to a close, aren't we?
Yeah.
So number 1, it looks as though is what health inequalities now exist in mental health care, especially regarding minority and marginalised groups, and how do we address them? Second is, how has the accessibility of services been affected, and what are the barriers to use for marginalised and minority groups? Third is, what is the impact of COVID-19 on the needs for community mental health care, including acute and crisis care, and how do we meet these? Fourth is, what are the social and economic impacts of the pandemic on people with mental health problems and their families, and how to manage them? Very important. Fifth, how to improve integration of NHS care with voluntary, charity and other sectors to deliver mental health support in times of high demand. Sixth, how have the needs of children and young people been affected by the pandemic, and how to address these? Seventh, what is the impact of loneliness and isolation on people, and how to support isolated people? Eighth, how has the pandemic impacted the adoption of telemental health and how to optimise it? Ninth, what is the impact of the pandemic on inpatient care mental health act use and strategies for managing these? And then 10th, what is the impact of COVID-19 on mental health, general population and service users, and how to address these? Thank you very much for all those who've taken part in that voting and that selection of priorities. And as I say, we will be considering that alongside everything else that's happened today. So we're coming to the close of our day. I want to thank again everybody who's taken part, everyone who's come along, listened in, chipped in, posted comments, asked questions. It's been greatly appreciated. Thank you for those who gave presentations. I won't name you all now, but thank you for those who have. Thanks everyone who's been working behind the scenes to make this happen today. Lots of people behind the scenes pulling big levers, I imagine. I don't know how they do it to make us go into rooms and things, but it's all magic as far as I'm concerned, and much appreciated. Just a couple of closing thoughts from me. Lots and lots of stuff, and quite overwhelming, and the speed of all this is mind-blowing at times. I think a big message for all of us throughout all of this has been the massive importance again to make sure that people who use services, people with mental health problems, survivors of services, service users, must be at the centre of deciding research questions and be at the centre of conducting that research and taking part in it. And we do try very hard to do that in the mental health PRU, and I've no doubt we're going to reflect and learn lessons from the last year and in the couple of years going forward to think about how we improve that. But I think it is a big lesson for everyone about how do we make sure that the voices of service users, survivors are absolutely at the centre. The other thing that came across for me today, I think the whole issue of we've really got up our game on improving the involvement of minority communities, both in our staff groups and in our research and everything. That's massively important. And then the other bit that struck me was just in today, we heard presentations from people talking about surveys, massive systematic literature reviews, smaller qualitative in-depth studies, use of big data, and we heard about stuff Mark was talking about that's taking place in the service user-led movement and stuff. They're all different designs, all different types of methods and methodologies. And I think that's really exciting and brilliant. And we learn different things from different aspects. But I also think we need to be thinking about how do we combine those? How do we integrate them? And how do we cross-pollinate across those different approaches? I was talking to someone just this week looking at using some of that big CRIS data, but combining it with qualitative interviews with people about their experiences and making those connections. And I think that's perhaps where some of the exciting future may lie, in looking at how do we use these different approaches to speak to each other, doing these different types of work. But I think that's probably enough for me and enough from all of us. We're 17 minutes over time. It's a crime in my book. And we didn't even get a chocolate biscuit or anything, did we? No, it's very weird, isn't it, doing it all this way. Thank you ever so much for everybody. I will shut up or I'll be here at 5 o'clock. Thank you and goodbye.